All right, I think we'll go ahead and get started. Welcome, everyone. Good evening. And on the last evening of ASCO 2025, what an incredible meeting for breast cancer. We're excited to have you here for Consensus or Controversy with my excellent colleagues, clinical investigators that will provide perspectives on the current and future clinical care of patients with metastatic breast cancer. I'm Dr. Hope Rugo. I'll be moderating this evening with, of course, the tremendous help of Research to Practice staff and Neil Love. These are our faculty members for today, I think well known to most of you, if not all. Harold Burstein, Director of Academic Partnerships at Dana-Farber Cancer Institute. Javier Cortés, the head of the IBCC International Breast Cancer Center at Barcelona, Spain. Rebecca A Dent, Senior Consultant at the National Cancer Center in Singapore and Director of all sorts of things there. Kevin Kalinsky, who's Director of the Division of Medical Oncology and the Glenn Family Breast Center at the Winship Cancer Institute at Emory. Joyce O'Shaughnessy, who is the Celebrating Women Chair in Breast Cancer Research at Baylor University Medical Center and the Chair of the Breast Disease Committee at Sarah Cannon Research Institute. I'm Dr. Hope Rugo. I'm Director of the Women's Cancers Program and Division Chief of Breast Medical Oncology at the City of Hope Comprehensive Cancer Center in Southern California. So in preparation for the meeting, Research to Practice conducted a survey of the faculty that are here. But we also asked questions of two additional breast cancer clinical investigators, Sarah Hurwitz from UW Medicine and Kamal Javeri from Memorial Sloan Kettering. Results from the survey are going to be shown after each section throughout the meeting, and we'll talk about some of the controversies. We also have conflicts of interest listed here. The relevant faculty conflicts of interest will be in the next few slides as we go through them. And then here are the disclosures for Dr. Love. Our commercial support for today is shown here. The Research to Practice CME Planning Committee staff and reviewers have no COIs to disclose. We're grateful for our supporters to make these educational practice programs work. So this program is going to discuss agents that are not approved. So we'll have non-approved uses of agents, also regimens. Please refer to the official prescribing information for each product for the approved indications. So this is where we're headed today. Here's our agenda. Dr. Cortés will begin by discussing HER2-positive disease. Dr. Kalinsky will discuss upfront therapy for HR-positive, HER2-negative disease, perhaps the most challenging section of the evening. Dr. Burstein will cover available therapies for patients with HR-positive, HER2-negative metastatic disease who have had progressive disease on CDK4/6 inhibitors. And Dr. O'Shaughnessy will touch on HER2-low and HER2-ultra-low disease. I'll discuss therapeutic strategies for endocrine-refractory, HR-positive metastatic breast cancer, and Professor Dent will finish out with the treatment of metastatic triple-negative breast cancer. As I mentioned, each faculty will go through their slides fairly quickly. This is an umbrella bird's eye view. And then we're going to talk about some pertinent case questions, and we'll see how the faculty answered them, and then we'll talk about the controversies. So let's start with the module with Dr. Cortés. Javier, you're on.
Thanks very much, Hope. Thank you very much to everybody for being here today. I will try to review very quickly the HER2-positive metastatic breast cancer setting in about 8 minutes or so. So these are maybe, forgive me, they are not all. I will make some comments about DESTINY-Breast9 in a minute, but maybe the largest improvements in HER2-positive metastatic breast cancer started with Cleopatra, showing how pertuzumab improves survival, adding to trastuzumab and taxane-based therapy. Emilia, looking at TDM1 in the second-line setting. HER2-CLIMB with tucatinib, adding on top of trastuzumab and capecitabine, so also an improvement in overall survival. And last but not least, maybe DESTINY-Breast03, showing how TDXD was better compared with TDM1, with this median progression-free survival in the range of 28.8 months. Remember, second line or beyond. 50% of patients in the second line, 50% in third line or beyond. So can we optimize the Cleopatra strategy? We all remember last year presented at San Antonio, the PATINA study. The aim of the study was those patients with stable, complete, or partial response after induction therapy with taxane or vinoelvin, trastuzumab, and pertuzumab were randomized to receive trastu with or without pertu plus endocrine therapy, with or without palbociclib. You all know the beautiful results, has a ratio 0.74, but a significant improvement in median progression-free survival from 29 months to more than 44 months, an absolute improvement in the range of 15 months. So earlier today, we saw the first data of DESTINY-Breast09. Remember, a randomized phase 3 study, TDXD plus placebo, TDXD pertuzumab compared with the classical Cleopatra strategy. Unfortunately, we did not have the data of the TDXD plus placebo arm. Maybe the number of events were not ready at this time. I don't know if this is because we require more events or just because we really have lower events compared with TDXD plus pertuzumab. Nevertheless, progression-free survival being the primary endpoint. Here we have the curves. Remember, has a ratio 0.56, and the median progression-free survival moved from in the range of 27 months to almost 41 months. A beautiful improvement in median progression-free survival. Regarding the adverse events, nothing unexpected, more nausea events, some diarrhea also to take into account, nothing that we do not know with a TDXD, and we would like to remember us that about 12% of patients did have ILD pneumonitis, being grade 5 in 2 patients. Regarding left ventricular ejection fraction, numerically higher, 11%, great majority, grade 1 and grade 2 with TDXD. This is something that is a trial that we are conducting in Europe and also in the United States, try to demonstrate if we can go for an induction therapy with TDXD 6 times, followed by maintenance with trastuzumab and pertuzumab with or without endocrine treatment, depending on the hormone receptor status. Some comments about brain metastases. They are quite frequent in the HER2-positive and metastatic breast cancer setting. About 50% of patients will develop at some times brain metastases. Also very significant in patients with metastatic TNBC. And we should not forget that it depends, obviously, if the patient does have distal metastasis or not. And one important aspect is that the frequency to appear brain metastasis is quite stable over time. So the patients would have a risk which is not higher or lower across the time. So what data do we have in patients with brain metastasis? We have to start with the HER2 climb. Remember, in this phase 3 study, patients were allowed to be included with stable or with unstable brain metastasis. This was the primary data. Progression-free survival and also overall survival was improved with tucatinib, and in those patients with CNS metastasis at baseline, again, stable or unstable, beautiful improvement in progression-free survival and also beautiful improvement in overall survival. Based on this study, many physicians think about tucatinib as the best option for patients with brain metastasis. Nevertheless, at ESMO last year, we knew the data for DESTINY-Breast 12, 2-cohort phase 2 study, large phase 2 study for patients with brain metastasis and without brain metastasis. All patients receive TDXD. Look at here, the median progression-free survival in those patients with brain metastasis. Again, beautiful curves and an amazing overall response rate. Remember, in this cohort, all patients did have brain metastasis. This just to make some comments about a paper we presented at San Antonio 2 years ago, showing that TDXD also works in patients with pathological confirmed leptomeningeal carcinomatosis. You can see here only 7 patients, 3 and 4 of them with HER2 low and HER2 positive disease, median overall survival 13 months. Small number of patients, all pathological confirmation, but beautiful data. Just to remind ourselves, more data we have, the NALA and the FILA study, other TKI inhibitors, also adding activity. In the NALA study, capecitabine was superior to capecitabine for progression-free survival, not for overall survival. And in the FILA study, similar to Cleopatra, but adding pirotinib instead of pertuzumab, also very nice progression-free survival curves. Finally, one other drug that is approved in some countries, the United States at least, margetuximab, which is a very elegant, very similar to trastuzumab. It changes in 5 amino acids, more immunogenic agent. Margetuximab chemotherapy or trastuzumab chemotherapy, around my phase 3 SOPHIA study, showing an improvement in progression-free survival, basically depending on different polymorphisms. Finally, just 2 or 3 last slides. There are other ways to activate this signaling pathway, not only by amplification or overexpression of HER2. We also could have mutations in HER2. These are the most frequent mutations. And this just to show you maybe 2 slides, very interesting. This is the paper by Hyman published in Nature Medicine some years ago, showing that neratinib alone or neratinib plus fulvestrant could achieve in the range of 30 to 40% absolute responses in patients with mutations in the HER2 gene. These patients, the majority of them are HER2 negative tumors, again, HER2 mutations. There's some data also adding trastuzumab on top of neratinib and fulvestrant. In my opinion, this does not seem to translate into a benefit. Overall response rate 40%. So I think that neratinib and fulvestrant could be a good option to treat these patients. So this is my last slide. T-DXd might become the standard of care for patients with HER2-positive metastatic breast cancer in the first-line setting, but in my opinion, induction strategy is something that should be explored, and maybe optimizing the maintenance therapy is something that could be clearly of interest. Brain metastases are very frequent. T-DXd works, tucatinib works, and the best drugs we have also work also in the brain metastases. Many other drugs are being explored. And last but not least, I think that HER2 mutation is something that we should think about 1.5 to 2% of patients with HER2 negative disease might have HER2 mutations, and maybe neratinib is a drug that should be considered here. So Hope, I would like to stop here. And
Thank you.
The floor is all yours.
Wonderful. That was great, and congratulations for staying way on time, which is fabulous for us. So this was a survey that was done for everybody before we actually came to ASCO 2025. So we were making our votes, just to keep in mind, before there was any information publicly, and as you know, the abstracts weren't out either. So the first question, you can see there was equipoise for. This was if the phase 3 DESTINY-Breast09 trial that you just heard about confirms the positive press release, how would it affect your initial management of ERPR negative HER2 positive metastatic disease? So you can see that everybody here, the vote before ASCO, would have prioritized T-DXd pertuzumab over THP. And then if you go to the next case, this is a similar patient. But this patient has ERPR positive disease, HER2 positive. No change, except for one of our colleagues, Dr. Javier, who would have prioritized THP in a patient with ERPR positive disease. So just one quick question. Javier, would your votes for either of these cases have changed based on what you saw here at ASCO?
Well, my point is that if I have to prioritize or to decide between trastuzumab deruxtecan, pertuzumab, or THP, my answer is very clear. The point is that, in my opinion, one thing is what I would decide, another thing is how I would treat my patients. So my choice would be a Demeter-like strategy, with some induction with T-DXd and some follow or some maintenance with HP-based, whatever the strategy is.
We'll go on and talk about some of the other cases, because that is, you just like planted the next question. So if T-DXd pertuzumab receives regulatory approval in the first-line setting, will you use maintenance therapy, and what regimen would you employ? So for ERPR negative disease, there was, again, equipoise with trastuzumab pertuzumab. But my colleagues all wanted to keep it going forever. But I voted to stop after 5 or 10 years, which is what I do in clinical practice. So we'll ask everybody a little bit more about that in just a moment. But in the ER-positive setting, we also had relative equipoise. There were a couple of people, 3, I think, who were more uncertain, 4, I guess, about whether or not we should add palbociclib or a CDK4/6 inhibitor to trastuzumab, pertuzumab endocrine therapy, a la the PATINA trial, as part of the maintenance strategy. So, Hal, let me ask you first, if you're going to give TDXD first line, will you use a maintenance approach, and would your vote have changed at all?
Sure. Well, first, I think it's a really important study, obviously, and we all picked it to be the winner because we'd seen previous data from DB07, which was a similar study of TDXD with or without pertuzumab in the first line, and it had really good outcomes. These were presented about 2 or 3 years ago, and so the expectation was that TDXD would be the winner. Something really important to remember about the Destiny Breast 09 study is that patients in the TDXD arm were treated until progression, whereas patients in the THP arm were treated for about 6 or 8 cycles, and then they dropped the taxane chemotherapy and continued the maintenance therapy already. And in fact, they didn't do what most of us would do in clinic, which was to add an endocrine agent. The other dilemma with the study is at crossover, because of the demographics of the study, a lot of patients really did not get what we would think of in the US at least as being standard of care, which is ongoing anti-HER2 directed therapy. They might have gotten chemotherapy alone or various regimens. So the drug clearly works. We've seen great results from Javier's DB03 study and a lot of other trials. And the question is, how do you best use it? And I think for many patients, the response rate, which was reported, was 85%. So they're all going to respond to this regimen. And at some point after 6, 8 months, I don't know exactly when, it depends on how the patient's tolerating the product. At some point, we'll probably take a break from the trastuzumab deruxtecan. It does have cumulative toxicities. There are persistent risks of ILD. There actually were more fatalities from the drug in that arm than on the other arm. And we will go to a maintenance program, which is both less toxic and can be very effective, as was shown in the PATINA study, for the ER positives or just in routine practice for the ER negatives.
Okay, well I think that shows you the maintenance. We'll get maybe honed down on the details a little bit before we go on to the next one. Rebecca, so if you're going to give a patient a maintenance approach, give TDXD, stop, how long are you going to give the maintenance? And ER negative, ER positive, and you weren't completely sure about adding a CDK4/6 inhibitor.
So first of all, I really echo Hal's comments that, I do see it as an induction. I think we aren't going to continue trastuzumab deruxtecan forever. I think it's important for everybody in practice to say that this is giving us an option. We now have someone who has brain metastases. This is a compound that is highly penetrant to the CNS. People really go from the ECOG of 3 to 0. And this really does give us an opportunity to give it earlier line, but it's not necessarily for everybody, and we don't yet have the biomarkers to tell us who. Now, in terms of the maintenance phase, the reason I put plus or minus, we're not supposed to consider regulatory issues, but to be honest, it's almost impossible not to. Mm-hmm. But I also think, how patients emerge after their induction, whether it's THP or whether it's trastuzumab deruxtecan, pertuzumab, how they feel after they come off that therapy is kind of variable. Some people are tired and they're not quite ready to jump into another sort of let's get used to symptoms. So that's why I put plus or minus, because I think it's quite variable. If the heavy burden of disease at the beginning and we're putting them on maintenance, then yes, I would go to a CDK endocrine. If they have a very low burden. Now, do I stop the HP?
Do you ever stop? Yeah.
Yeah, so I think we've all got these patients in our clinic, and we get to 5 years, and we're like, yay. And then, we sort of say, okay, I discussed it with my colleagues, there's ongoing long-term data, and it is variable, but I would say at 5 to 10 years, I'm a bit like you. I sort of start discussing it, but it's hard to be the person that stops it if they're covered to get it, and so then you have a dialogue with your patient about how you're going to monitor. But I think after the 5 to 10 years marks, that's when we think there might be some immune phenomenon that it might be reasonable to start thinking about it.
I've certainly done it successfully. And there's a study actually looking at stopping a little bit earlier to stop her. So now your patient gets first-line THP, so Cleopatra-like regimen, but then she has systemic disease progression extensively with multiple brain mets. So you can see there was equipoise about TDXD. I think mainly because it's much easier to give TDXD than the HER2 climb regimen, although that's clearly an option. We had different options and everybody chose whether the patient was asymptomatic or symptomatic that we would change to trastuzumab deruxtecan. So the other part that Javier was talking about was HER2 mutation testing. And the big question is, do you test for HER2 mutations? We all send next-generation sequencing now, so we are getting that result. So we are testing for HER2 mutations, which are more common, as are all the weird mutations in patients with lobular cancer. And then the question was, would you give neratinib-based therapy to a patient with progressive HER2 mutant metastatic breast cancer, and would it depend on receptor positivity? You can see, again, equipoise. Joyce, do you want to just comment on that? Are you giving neratinib? Are you giving any other oral TKI?
I do use neratinib and have successfully with trastuzumab adding an endocrine agent if it's ER positive. I would also utilize tucatinib for sure, and there's also some data, older data with lapatinib, but mainly it's neratinib is the first choice. I think we have the most robust data with the neratinib from the Summit trial, and almost everybody responded. That's a very impressive looking waterfall plot, So that's my first go-to is the neratinib.
And I think what mostly people have used various TKIs in this setting. I don't know if Kevin, I think I'll get this next question with you because of your next talk, but 65-year-old woman who has HR-positive HER2 mutant breast cancer, multiple Mets 9 months after starting adjuvant ribo and anastrozole, all of the mutations we look for are not there. What treatment would you recommend? And you can see that there was less equipoise here than any of the other questions we've asked so far. So what would you do in this setting? Kevin, you had recommended the triplet and TDXT if the patient is really symptomatic, and I think that there were a number of other recommendations.
Yeah, I mean, I think that as we've mentioned, the data from Summit, we saw some really nice activity. I also say at ESMO Breast, we saw some activity with tucatinib-based treatment, and so I would say if I'm able to get access to that as a regimen, I actually would probably prefer that. Those data seemed impressive, though, of course, we have more with Summit. And then, as I mentioned, as we've seen, we have really nice, robust responses with TDXD, so that's why I'd put in if somebody was really symptomatic. But again, in general, in the setting of a HER2-positive disease, meaning amplified disease, tucatinib is quite an active agent, which is why it may move up for those who are HER2 mutant for me.
Yeah, I think that, and then, of course, you're still giving the fulvestrant was helpful, and I also thought that tucatinib data, a little bit less toxicity and quite impressive responses. So maybe it'll be something we'll see coming up more in the future. So I'll just ask, before we start with Kevin, Hal, you were the only person who didn't recommend that. Would you at some point?
So I confess I'm not sure I read the question correctly. I'm not sure I caught the HER2 mutated thing. But it was actually, for those who still have the guidebooks, there was a really nice poster at the meeting from MD Anderson where they're using trastuzumab deruxtecan in this patient population with the point mutations. As you know, that's FDA approved for treatment of mutated lung cancer. It had a high response rate in the same group of patients. So I will revise my estimate and go along with the Texan Dr. O'Shaughnessy here and probably give TDXD in this case.
All right, so a lot of exciting new ways to treat this cancer, and we're going to hear about some exciting new data from ASCO from Kevin about upfront therapy that is individualized for HR-positive, HER2-negative disease.
All right, I'm going to try to take a breath as I go through all of this very quickly. So as we can see in this slide, there's been a lot of treatment changes. The landscape has really evolved with hormone receptor-positive disease, whether it's endocrine-sensitive disease, targeted therapies. We'll hear more about this as we continue, and then antibody-drug conjugates. For us, CDK4/6 inhibitors in the metastatic setting, and of course in the adjuvant setting as well for patients with intermediate or high-risk patients, we utilize CDK4/6 inhibitors. One can see with the 3 that are currently approved through much of the globe that there is a consistent progression-free survival benefit with some of the studies showing an overall survival benefit. To move on to ESR1 mutations, one can see that this is a mutation that associates with acquired resistance, and when patients have metastatic disease in the first line, the rate of having ESR1 mutations is low. We've seen that from data sets including PADA-1, and then it can go up to about a third to 40% based upon the particular study. So I'm going to talk about the PADA-1 study, which to clarify is a phase 2 study, which is looking at patients. This was a randomized study that was asking the question, if patients are on an aromatase inhibitor and CDK4/6 inhibitor, in this case it was palbociclib, and if patients had the development of an ESR1 mutation that was detected by circulating tumor DNA, they were randomly assigned to continue what they were taking, and then at progression switch to fulvestrant plus palbociclib, or switch immediately to fulvestrant plus palbociclib. And one can see that it was an improvement with progression-free survival with immediate switch. And then this is looking from the time of randomization to the time that they not just progressed at that first regimen, but went on to progress at the subsequent regimen. And again, in this phase 2 study, one can see that those who were randomly assigned to fulvestrant plus palbociclib at the time of randomization did better. So this has really served as the rationale for the data that we saw today, which was this meeting with SERENA-6. So this was a study in which patients were on an AI and CDK4/6 inhibitor, could have been any of them. They were on that for at least 6 months, and then they started to have ESR1 mutation testing via the Garden assay. That was done every 2 to 3 months, and one can see that they screened about 3,000 patients, and then they detected an ESR1 mutation about 500 of those. One can also see that at that first test, which is about 51% of patients had a positive detection of ESR1 mutations, but it's also important to clarify that that was not, at 6 months for the majority of those patients. And then they were randomly assigned, if they did not have disease progression, you can see at the bottom of the slide, the rate of patients who had actually had disease progression at that time. So then patients were randomly assigned to, patients took 3 pills. They continued that CDK4/6 inhibitor, and then they either got camizestrant and took a placebo for the AI, or vice versa. And the primary endpoint was looking at progression-free survival. You can see the secondary endpoints that are listed here. I just want to highlight a few things. One, you can see the rate of visceral metastasis was about 40%. I already mentioned the rate of ESR1 mutation detection at that first test, which was about 50%. One can see, this is something that I wanted to emphasize, that the time that they had started their AI and CDK4/6 inhibitor to the time that they were randomly assigned was about 23 months, okay, from when they started that AI. The majority had palbociclib. You can see the list of ESR1 mutations here. And when they look at progression-free survival, one can see that those who were randomly assigned to Cami had a median progression-free survival at 16 months compared to 9 months if they had continued on that AI. These were some data, I imagine this may come up as part of the discussion, which was just looking at the time to deterioration, where they're looking at the ERTC QLQ-C30. And one can see that patients seem to report, in terms of their global health status and quality of life, that they felt better on camizestrant. But this, you can also see that there was a quick splitting of the curve, also recognizing that those patients actually did not have progression radiographically at that time. So this is an interesting finding that is worth some discussion. And then when we look at PFS2, these data are early, but one can see, and again, the time point that's being evaluated here is the time that they were randomly assigned, not the time that they had started their aromatase inhibitor, the time that they were randomly assigned and then had PFS and then PFS2, and there is this trend towards improvement with camizestrant, but those data are early. Ultimately, the addition of Cami, which you're seeing on the left in terms of the green, seem to be some side effects, hematologic side effects that might be associated with the CDK4/6 inhibitors. There is a unique side effect of photopsia, which is essentially, it's been well described. Erica Hamilton describes this as when you walk into a movie theater and your eyes adjust, that's what patients report that symptom to be like. And so those are the data from SERENA-6. And just to shift for the latter part of this, where we talk about PI3K inhibitors. And there's been interest in this pathway for some time. One can see the development. Of course, we had mTOR inhibition approved with everolimus in our patients, and then alpelisib and capivasertib, and more recently inavolisib, which I'll talk about. And now we have PI3K mutant selective inhibitors. So we previously seen, and we have approval in the US for the triplet of inavolisib plus palbociclib plus fulvestrant, based upon the INAVO120 study. So this is a very specific patient population. These are patients who had endocrine-resistant disease, meaning their tumors progressed within 12 months or on their adjuvant endocrine therapy. And so this is first-line setting for those endocrine-resistant patients. These patients had measurable disease with PI3K mutations. And again, the control arm here is just giving fulvestrant and palbociclib. And so these are the updated data that we saw in terms of progression-free survival. We can see a difference with the triplet compared to the doublet of 7 months versus 17 months. And then we saw survival data. And this is the first time that we have seen an improvement in survival with the PI3K AKT mTOR pathway inhibitor. And one can see that the triplet, the median overall survival was 34 months, and for the placebo arm, it's 27 months. There was a lot of conversation about the fact that there was not a crossover in the study, but also these patients had bad disease, and a number of these patients progressed to receive chemotherapy, and some of the patients actually had died shortly after the time that they had progressed on frontline. This is just a list of some of the treatments that patients had received. I'd already mentioned this, but those patients who were in the placebo arm, one can identify that the second line was more frequently chemotherapy compared to inavolisib. These are data that are actually showing the time to subsequent chemotherapy, which for our patients can be important, given that in this subtype of breast cancer, it's a marathon, and we want patients to remain on endocrine-based therapy for as long as they can. And one can see that there was a near tripling in terms of how long it took for patients to get chemotherapy. Toxicities, no new toxicities that were necessarily described. Just to talk about this, the main issue can be stomatitis, and the utilization of oral steroid rinses can be helpful. And then hyperglycemia, you can see the majority of the hyperglycemic events are lower grade, though about 7% have grade 3 or 4. And then there's some reporting of rash as well. And this is my last slide, which is just mentioning the different agents that we have available that target this pathway, some of the differences in terms of diarrhea and rash and hyperglycemia and stomatitis. It's also worth mentioning before I conclude just that the different studies had different cutoffs for hemoglobin A1C and glucose. And so when we look at these sorts of rates, it's important to keep that in mind because not all of the studies were similar in terms of their inclusion criteria.
Thanks very much. That was great. So before we start with this rather controversial area, I'm going to just ask a couple of questions to you guys from the audience. One question, I think we talked a lot about maintenance. Would you consider a re-challenge of TDXT at the time of progression on maintenance if you use maintenance therapy? Javier?
Sure, definitely I would. Yeah, I think it makes sense.
Yes. I think the only time you might not is, I suppose, if it was 2 weeks or something, but otherwise,
Right.
I think we all would.
The treatment-free interval is reasonable.
One interesting factor that we saw in DB09 was that patients weren't exposed to the standard adjuvant therapies, right? Similar to Cleopatra, which is something surprising. There wasn't a lot of adjuvant exposure to pertuzumab and trastuzumab. So does that affect at all your interpretation of the data or use? Rebecca.
Right now, no, it doesn't. I mean, I think, the Cleopatra data was the same issue, and I think that's the world that we're living in now, is that what we see in the real world can't keep up with the pace of the clinical trials. But I think as time goes on, I think we will rely a little bit on real world data to see what's happening in clinical practice, because, what we saw with the Amelia trial and we saw with TDM1, going back, I guess, more than 10 years now, when we started using TDM1 in the real world, when people had gotten THP first line, I was not seeing that benefit of TDM1 second line. So I wonder when we start using that, we might see a different activity in the real world. We'll just have to see.
And a related question, our last question on HER2-positive disease is that, Joyce, I know a lot of people have been very heavily pretreated. So now, you have a patient who will have had THP, TDXD, and the HER2 climb regimen. What are you going to give them next?
I do like to use TDM1 after, particularly after a TKI, if you do TDXD and then the TTC regimen, tucatinib, and then TDM1. But also by that point, a lot of people have brain metastasis. And so I still use the NALA regimen with the capecitabine and the neratinib. I have found that to be quite non-cross resistant in heavily pretreated patients. And then otherwise, just chemotherapy and trastuzumab usually.
Great, thanks. So let's talk some about this survey where we ask questions. So we have a patient who has de novo, ER-positive, HER2-negative metastatic disease with asymptomatic bone metastases. So the question is, what would you give this patient if a biomarker evaluation revealed a PIK3CA mutation? There is equipoise. Everybody would give a CDK4/6 inhibitor and an AI. Most ribo, a couple palbo. How do you decide about palbo here?
I like giving palbociclib. It's a really good drug. It's very well tolerated. It's, and I knew that the data were going to be positive for Inavo and overall survival, and it's all built on palbo. So I'm ready to just add the inavolisib here, having come out of ASCO. I don't think it makes a difference which CDK4/6 inhibitor people get. Most practices I talk to have picked one and they start with it. I will caution you that I think you're at maximal tolerability with the inavolisib palbociclib regimen. I don't think it's easy to just substitute abemaciclib or ribociclib into that cocktail if that's what you're looking at.
And that's a really important point, I think, about how we can mix different drugs. We need an evidence base. So let's just look at the other question. A 65-year-old woman who has ER-positive, HER2-negative, IHC0 breast cancer with multiple metastases 2 years after completing 5 years of adjuvant and anastrozole. So what endocrine-based treatment would you give this patient, depending on the biomarker? So the big difference between the two columns is that the patient on the right side has a PIK3CA mutation. The patient on the left does not have any targetable mutations. So this is a patient at 2 years. So the real question, I think, is how you're going to incorporate different data into this situation. So you can see there's a little bit less equipoise. I think everybody would use a CDK4/6 inhibitor and endocrine therapy. Some people would choose fulvestrant at 2 years, but most of us an aromatase inhibitor. But with the PIK3CA mutation, Joyce, you chose giving the triplet, inavolisib, palbo, and fulvestrant, although the patient doesn't really fit into the eligibility. You're thinking there?
Because there's not a whole lot of biologic difference between recurring within 1 year of finishing and recurring within 2 years. It depends on the big picture, multiple metastasis. Here, just 2 years later with the PIK3CA, we saw how early those curves split. It's the PIK3CA that's really a problem here, so I really want to go after it. So I just think in this kind of aggressive biology, when we have a triplet, we should use it.
And Kevin, would you, you had mentioned that you would use ribo and an AI. Is there any situation where you would use the triplet in this setting?
I don't think so. I think that I agree with the point that, really what's the difference biologically between 1 or 2 years? There are associated toxicities, the stomatitis, et cetera. And so I do think, though, that there's definitely an opportunity for these selective inhibitors to be evaluated in this sort of space. Those seem to have a better side effect profile, and we have proof of principle, really, in terms of these endocrine-resistant patients from Inavo 120. So I think that there's an opportunity to expand that with these more well-tolerated agents, but also understanding other issues like giving 3 drugs and financial toxicity that we'd have to consider as well.
Yeah, I know there's certainly a lot of trials looking at this area. Rebecca?
Yeah, just combining both of those points. I think I put ribociclib in AI, but I think back to Joyce's point, it really depends what this patient looks like. If this patient has explosive disease, it's quite symptomatic, has a heavy burden of liver disease, I'll be honest, I would not give ribociclib because we know that this can result in transaminitis, and I won't know if it's the cancer progressing or it's the ribo. And so back to Hal's point, that's a place where the triplet, you're giving it with palbo, which is much better tolerated, you're targeting PIK3CA. So that's the time I would sort of step outside the clinical trial boundary if I could. If I had an aggressive patient who has a PIK3CA mutation, that's where that triplet, I think it plays a role.
So more disease burden and potential
absolutely.
organ dysfunction, but you still want to use the endocrine approach. So now we're getting into a patient who more fits into the Inavo 120 eligibility. So a 65-year-old woman, also ER-positive disease, IHC0. She has multiple metastases 2 years after starting adjuvant anastrozole. So she's on her adjuvant anastrozole. So this is more of a primary resistant disease. So you can see that most of us would give the triplet therapy in the first-line setting, even if a patient had a PI3 kinase mutation. I think then the question comes out if you have abnormalities in AKT, PTEN, or ESR1, PIK3CA, we maybe change a little bit here. So this is a patient who has a PIK3CA mutation. I'm thinking, who will we ask who gives the most different information here? So Hal, you're not really sold on the triplet in this setting necessarily?
Well, I think, look, the good news in breast cancer is that the vast majority of these patients are going to get multiple lines of therapy. And the question begged by many of the studies that we've already started talking about, like DB09 and like SERENA-6, is, what's the optimal way to sequence and utilize these drugs? And so, traditionally, I've been using CDK4/6 inhibitors plus endocrine therapy as first line, and then for patients who have a PIK3CA mutation coming in second line with a targeted drug. I think it's perfectly reasonable to use IPF, and I think the overall survival signal here gives a little more emphasis to that in this population. Though again, it doesn't ask the question as to whether it's better to give it in first line or second line.
So Javier, if you did give in this patient who could be eligible for IPF, if you gave a BEMA and fulvestrant, or in the ESR1 setting with imlunestrant potentially, or something like that, what would you do after that? How would you incorporate in a drug that targets the PI3 kinase AKT PTEN pathway?
So I think that, in my opinion, the first thing we have to think about is what we think, which is the driver of the resistance. So for me, this is very, very important. This is a patient with a primary resistant, and the driver here seems to be AKT, PIK3CA, whatever the mutation is. And I think that ESR1, in my opinion, is less likely to be the driver in this. If you have ESR1 and PIK3CA, I think PIK3CA is more important in this patient with primary resistant. In the secondary resistant is the other way around. That's why, in my opinion, I would prioritize the AKT pathway inhibitors. Of course, if you don't have anything to be targeted, so if you have Capiva, for example, for AKT or PTEN, but the patient has not received CDK4/6 inhibitors with an improvement in survival, I would go for CDK. So that's why IPF for me is the primary option here. But if not PIK3CA, I would go for Abema, fulvestrant first. I would consider Capiva afterwards.
In the second line, after
I would say if I would have the opportunity to combine 3 drugs, then I would go for Capiva, CDK, and endocrine therapy, but I can't do that. So that's why.
That's being studied now in Capitello 292. But what would you do next? So you got a BEMA fulvestrant. Now the cancer is progressing. You have these mutations. The partners with our PI3 kinase inhibitors, AKT inhibitors, are all fulvestrant. So
it depends. It depends.
What would you do?
So if the disease progression is very quick under CDK and Abema, I would go for Capiva. If it is not the same, I would consider imlunestrant or elacestrant with or without Abema.
And so let's talk about the next one, where we're really talking about SERENA-6 here. Do you think the results of SERENA-6 justify the use of ctDNA monitoring for early detection of ESR1 mutations, and how often would you do that? So some of us had a little bit of equipoise there, waiting to see the data. Otherwise, I think that we were all checking it reasonably at the same time. And then our 2 external docs said no, they weren't ready to do it based on what they knew pre-ASCO. So let's ask Kevin, do you want to comment on that?
Yes. Also, I just want to go back to one of the things that we were just talking about just for a moment. There are data from the original development with Capi, where from phase 1 studies, but also NCI match, where there were some patients who had prior fulvestrant and they had an AKT mutation. They still seem to benefit from the addition of capivasertib. So
good point.
There are some data. And then I want to change my vote here. We had not seen these data. I do feel like, first of all, I also want to just give a comment that for those of you that did not see Angie DeMichel's discussion of it, really is a masterclass of a discussion. It's really thoughtful. I think that she highlighted some of the issues. I think one of the things, beyond the fact that, I know we're saying regulatory and reimbursements aside, we don't have CAMI, but even if we had CAMI, I really do think that we need additional time. We need additional time to look at PFS2. I also think this is the point that I was trying to make, just looking at the time. One of the questions that came up was, well, what about, just, are we just, driving things forward? And I think, if we look at the time that patients had started on their AI, as opposed to the time to randomization, I think that's important, look in subsequent analyses, and the data are just too immature.
So you're not sure that you would check now regularly?
I would not check now regularly, because
Okay.
what would I do?
I'm changing my vote too.
You'd change your vote too? All right.
No, I think it's important for people listening, to be honest. The last 24 hours, everybody's been talking about this nonstop.
Well, let me
So-
just ask you before.
Okay.
But
I'm going to ask you this
I
question.
changed as well in the way.
Okay, hold on. So
What?
hold on one second. So we've got this patient, now, and they fit into the Serena-6 study, so they're starting their AI. Would you change to a SERD if this was approved and you could do it? Rebecca, why don't you were going to answer that question, so I'm going to.
No, thank you. I just wanted to reassure people sitting here listening that this is all driving us. We're having our own internal conflicts about this, because philosophically, I think we're all super excited about the fact that we're going to use a biomarker to potentially change our clinical practice, and we hope in the future we can substitute, blood tests to even actually monitor whether we have response. So philosophically, this is a really important step, but the question is, does this actually change the patient's overall outcome? And if we sequence the therapies, would we get the same outcome? So you can see, I think Kevin put in there, await maturity of PFS2 data, and I'm sure Hal and others would say the same thing. We want to see that we're not changing too quickly. We want to get as much mileage out of each therapy that we can, but we also don't want to miss a window to switch therapy. And that's the crux of the matter that really sort of gets us, that we're really struggling with. So I think we want to be progressive, and I think patients are going to drive this a lot, that they want to know, is this treatment still working? But it's kind of weird to be able to be told that your blood test shows, oh, you can be on this for another 9 to 12 months and it will still be working. It feels a bit strange to say, oh, let's switch you. So that's what I think I'm struggling with internally.
Yeah, and we all are, and we may change our minds in another few weeks.
Yes.
But Javi, I'm going to ask each
I
of
want to
you.
do an
Hal, hold on
audience
one
poll.
second.
Can I do an
Hold on.
unofficial
No,
audience
you got to
poll?
wait. So Javi was next. So the main thing is it's got to be really short.
Just one
So
comment.
Javi and then Hal.
That one comment. I said I'm not sure before. Maybe today I will say probably yes. Why? Because quality of life was impressive. And quality of life, in my opinion, is something to take into account as well.
Okay, what did you want to pull for, Hal?
Okay. How many of you have ever checked a tumor marker in a patient with breast cancer? Okay, you have a patient. Their tumor marker starts at 400. They get treated. It goes down to 117. Then it goes up to 146. Do you change their therapy? How many say yes? How many say no? How is the Serena-6 data any different from that?
We have randomized trial data showing
Exactly.
it's an outcome.
We have the only randomized data we have in metastatic disease are when they did early detection of circulating tumor cells, and that actually detecting them early did not
Didn't
change
work.
the long-term
You're
outcome.
absolutely right. Didn't
So
work.
I think that, it's a win for the drug. It's clearly an active drug in this setting, and we will be using the drug assuming it's FDA approved. But I do not think you need to check every 8 weeks to look for emerging ESR1 mutations in patients who are not otherwise progressing. And again, I would echo what Kevin said, which is that Angie D. Michel gave a beautiful discussion, and I would recommend that to anyone.
So yeah, you can see that this is an area of huge controversy, and we are all still discussing this a lot. So I would say that it's not a you have to do this on Monday kind of thing. It's a idea in evolution, very exciting in evolution, and so you're going to hear more. So we're going to move on, and Kevin might be able to get it in later. Hal's going to talk to us next about therapies after CDK4/6 inhibition.
Well, good evening, and God bless you all for staying for another evening program here. It's wonderful to have such a crowd. So we're talking about treatments now for patients who've progressed on their initial therapy, and I think what's really emerged in the past couple of years for hormone receptor positive disease is you're going to have a pick list from column A of endocrine therapies, tamoxifen, aromatase inhibitors, fulvestrant, and oral SERDs. and maybe a Protac before too long. And then you're going to have a list of targeted drugs from column B, CDK4/6 inhibitors, PIK3CA inhibitors, AKT1 inhibitors, mTOR inhibitors. And more what we're seeing is that in multiple lines of therapy, you're going to have one from column A and one from column B, and that's going to be the pattern. So again, the questions are less about really, are these drugs active, but can we begin to define optimal sequences and look at that? So the first study we'll look at here is the Capitello 291, which you've already alluded to about capivasertib. This was a study for patients, all of whom had, the vast majority of whom had progressed on CDK4/6 inhibitors with an AI and were randomized to fulvestrant or fulvestrant plus the AKT1 inhibitor capivasertib. And as you know, that led to an improvement in progression-free survival in those tumors that had a AKT pathway mutation, which included PIK3CA, AKT, or PTEN loss. The major advantage of capivasertib here is there's a lot less hyperglycemia than there is with alpelisib. Now, I don't know if that's exactly because we only see the patient, you give the drug for 4 days in a row, and then you stop for 3 days, and then they come back to the clinic. And I've always wondered if we just see less hyperglycemia because we don't actually see them when they're on the drug. But regardless, you don't have to worry about the glucose so much, which makes it a lot easier for your nurse manager and everybody else to take care of the patients. The other class of drugs that's emerged has been these oral SERDs. So these are oral medications that are fundamentally, in many ways, similar to fulvestrant, but have the convenience of oral availability. And in that way, they actually get much higher much higher pharmacologic levels. Many of you may know that one of the historic problems with fulvestrant is it's very hard to achieve very high levels. So they offer some real clinical advantages. The first and only one approved at the moment has been elacestrant, which was approved based on the Emerald study shown here. Patients had had prior CDK4/6 inhibition and 1 or 2 lines of prior endocrine therapy and were randomized to an ongoing treatment with an AI or fulvestrant, largely fulvestrant, or to the oral agent elacestrant. And what was shown is that there was a modest improvement in progression-free survival. You'll note that about 30 to 40% of patients are quickly resistant to all these endocrine manipulations. But in the subgroup of patients who had an ESR1 mutation, there's an improvement in median progression-free survival as shown in these curves. So if you look at various subgroups, they can start to parcel it out. There was a lot of early interest in the fact that patients who'd had a more extended CDK4/6 treatment did better. That's really just a selection of tumors that are still sensitive to endocrine therapy. Remember, the key point about an ESR1 mutation is Darwinian selection has identified these tumors that are incredibly sensitive to hormone manipulation still. They're still dependent on estrogen receptor activity for its growth. That's the selection. You select out an activating mutation for ESR1. So these are very sensitive to hormone manipulation, so they tend to, all the things that predict better outcomes with hormones tend to be prognostic factors in this group. The major side effect that patients talk about with me is the upper GI issues of nausea and vomiting. The rest of it's actually pretty manageable. The other drug that's come forward in this space is imlunestrant from the EMBER-3 study, which was reported at San Antonio and published at the same time in the New England Journal of Medicine. There were 3 arms to this trial, imlunestrant, the oral SERD, versus fulvestrant or exemestane, versus a combination of imlunestrant with abemaciclib. In the first analysis, here as well, we saw that in the tumors that had an ESR1 mutation, the oral SERD performed better than the standard of care, 4 months out to about 5.5 months median PFS. No benefit if the estrogen receptor was wild type. Interestingly, in the cohort of patients who got the combination, actually there was a significant improvement in PFS. And if you look particularly on the left, you're looking at patients who'd had prior CDK4/6 inhibition therapy, then got imlunestrant alone versus imlunestrant plus abema, you get about a 9 months median PFS. Hint, hint, if you look at SERENA-6 and you say, okay, you've got an ESR1 mutation, you switch from an AI plus a CDK4/6 inhibitor to a SERD plus a CDK4/6 inhibitor, you got about a 7 months improvement in PFS, you more or less get the same thing here. So again, I think it's questioning whether you need to act urgently on the molecular testing. So this was a slide I made for the San Antonio discussion, just pointing out that with all the weaknesses of cross-study comparisons, it does look like ongoing combination therapy with a targeted drug, be it capivasertib, be it ongoing second-line CDK4/6, as Kevin has published on, or switching to a SERD with a CDK4/6, probably gives the best second-line results that we see these days. So what's new here? Well, we saw data in the VERITAC-2 study on vepdegestrant which is a PROTAC. It's sort of like an oral SERD, but it's an oral agent. And to be honest, I had thought this might be the best-in-class drug going into this work because it was such a very interesting molecule. The warhead binds to the estrogen receptor. There's another part of it that's supposed to activate the cell degradation machinery, and then it was linked up. And so VERITAC-2 was a large global study looking at monotherapy of vepdegestrant versus fulvestrant. And what they showed was that, again, in those tumors that had an ESR1 mutation, there was an improvement in the median progression-free survival. If you look at the BICR results, it's a little better than the investigator reported, but not in the overall patients. In fact, if you look at the ESR wild-type ones, the curves sort of flip the other way. So on the one hand, this is now the fourth drug, if you're counting elacestrant, camizestrant, imlunestrant, vepdegestrant, which in ESR1 mutated tumors looks to be a little bit better than existing options like fulvestrant. At the same time, you got to say this is a disappointment in that I thought this drug might really break out. Like this might be a really better endocrine therapy than we've had with aromatase inhibitors or fulvestrant, even for unselected tumors. Unfortunately, it didn't achieve that, but it may make it to market, and I think the company intends to file with these data. Very well-tolerated product, lacks the arthralgias. Fatigue was the major side effect that was uniquely identified. So that's where we're at with endocrine therapy. The exciting news is we're going to probably, by the end of the year, have 3 or 4 of these oral SERDs or SERD-like products available in the market. The standard of care is quickly shifting towards combining everything, so there's actually less interest in some of the monotherapy studies than there had been previously. So something to keep an eye out on is, as these studies come forward, what's the safety and tolerability of combining these products with the various targeted drugs that we often use in second line, and how feasible will that prove to be. And finally, I think that, now that we have multiple agents here, looking at some of the other endpoints, and one of the really nice things that Kevin pointed out in the Inavo 120 study is, it looks like that adds another year or more before you need chemotherapy. I mean, I think that's a really clinically important endpoint for our patients, and looking at those kind of endpoints is probably something we should do more of. And now, Hope,
Excellent.
back to you.
Thank you. And thanks for staying on time again. So, just to sort of continue in this general vein of what we do after a CDK4/6 inhibitor and aromatase inhibitor in the first line, we now have a 65-year-old woman who has de novo hormone receptor positive disease, and she does have a good response, but she's experienced this disease progression 2 years later. So if she doesn't have any mutations found of the targetable mutations that we have, most people wanted to give everolimus or abemaciclib with another drug. So either with abemaciclib with imlunestrant, fulvestrant, exemestane, everolimus. I think we have a little less equipoise there. When we get to a patient who has a PIK3CA mutation in somebody who's progressed on ribo and anastrozole, most people are going to target the PIK3CA with a couple of our responders giving abemaciclib in that setting with imlunestrant. And then when we go down to somebody who has an AKT-P10, we really end up with pretty much the same recommendations across the group. So, Joyce, I think I'll ask you first. You would give abema and imlunestrant regardless.
Because of the nice graph that Hal put together, where if you look post-CDK4/6 progression, that the imlunestrant and the abemaciclib had the highest PFS. And at ESMO Breast, they showed all the various subsets of the PIK3CA and ESR1, et cetera. And regardless of that, it still has the same improvement in PFS. So I think that's the most highest PFS that we have. And I would definitely go with the capivasertib, the P10 loss. That's got a lot of phospho-AKT. I definitely would go with that next after that. But I think you could go either way with it. But I think based on the data from EMBER-3, right after, in the patients post-CDK4/6, that was the highest PFS.
So if we have a patient who, here we are, who has the same de novo ER-positive disease, ribo and anastrozole, 2 years of disease control, now with progressive disease. Now we have a patient who has an ESR1 mutation and no mutations in the PIK3CA pathway. Everybody's going to choose an oral SERD here, and some in combination with abemaciclib based on imlunestrant data, some elacestrant alone. And then once you start having a PIK3CA mutation, it only affects some people. And, there has been data showing that the work, as Joyce mentioned, is the combination may be effective even in that setting, so you could use sequential treatment. And the same is true as we get to the AKT P10, we're seeing a little bit more shift to using capivasertib next before, rather than abema imlunestrant. So, Javier, I'll ask you. You had said elacestrant in all three. You wouldn't. You're not a big fan of the combination.
Well, I am, but not in this patient. This patient is a 65-year-old woman. She had a good response. She was on treatment for about 2 years. So first of all, I don't think that the PIK3CA pathway is doing something here. I think that this is not a driver mutation for the resistance, in my opinion. More than 2 years later, this is a truncal mutation. It exists usually from the very beginning. So the mutation is there. The patient did well for 2 years. So in my opinion, this patient, the ESR1 mutation is doing the role. I think elacestrant with an 8.6 months in this patient population. I know that's a subgroup analysis, but nevertheless, 65-year-old women, 2 years afterward, elacestrant 8.6 months, great toxicity profile. I think it's a good choice. I'm not against abema plus imlunestrant. I think it's a very good option as well, or even imlunestrant alone here. So, but I think that monotherapy here is something good for this patient.
Yeah, we're all struggling a little bit without seeing overall survival data yet, and it will be difficult because we're really hoping everybody has access in sequence to the various effective drugs. So now the woman is 80 years old. She has de novo ER-positive disease. She gets ribo and anastrozole, 2 years of response. She has ESR1 and PIK3CA mutation, but no AKT1 P10. So what would you give this patient now? And we do see some combinations versus single-agent oral SERD. We asked Rebecca, you wanted to give the combination to our 80-year-old.
Well, I think, again, you have to take every case in context, right? There's 80, and then there's 80, and then there's, what their disease looks like. And, one thing I have to say is fulvestrant is extremely well tolerated. We used to whine about the injection and how difficult it was. But to be honest, it doesn't have, I find, both elacestrant and imlunestrant quite well tolerated, but it's not as easy as fulvestrant. And so I like the idea of giving them abema fulvestrant. I even think we haven't talked about fulvestrant and everolimus for the patients who have nothing that comes up and tunes their mutational profile. And if you titrate up the everolimus and you give your magic mouthwash, it's extremely well tolerated. So I think we really have to be a little bit more thoughtful when we think about an older patient and preserving quality of life. And they do tend to, I find, have a bit more endocrine sensitive tumors.
Would you use a dose escalation of abemaciclib, a la?
Absolutely.
And
there's some great data yesterday by Erica Mayer in the sort of adjuvant context looking at that. So yeah, I would always start with 100 twice a day. And then I know there's some difficulties with reimbursement, but in our older patients, I think it's really especially, we looked at the Monarch E study, Erica Hamilton presented data where almost 20% of patients came off abema without a dose reduction. They just came off. So I think if we started 100 twice a day, we sort of teach them how to do it. I think doctors are better now, too, at making sure they understand what it means and how to take it. I think the only issue is the diarrhea is a little unpredictable. So it's not like, you can say, okay, I've got it now. But I do start at 100 twice a day.
Yeah, I have found that when I start at 100, they never will take 150.
Yeah.
So now, there's, of course, published research data and your clinical experiences, although you might not have given all of these drugs. How would you compare the global efficacy of elacestrant to imlunestrant as monotherapy? And there probably will be patients where monotherapy is a better choice because of less toxicity. Kevin?
Yeah, I think that, I've been thinking about the comment that Rebecca made, right? I think for this older patient, I'm persevering on this older patient. I think if this is a patient who has bone-only disease, right? I just think that giving single-agent SERD makes sense, right? I think that when one has, visceral disease or you're concerned about having symptoms, et cetera, that's when I often would give combo. I was just stuck on on that particular patient.
But you feel relatively that the efficacy is about the same.
Yeah, I do.
We don't have any direct comparisons.
I don't have any direct comparisons, and I think that, as Hal had pointed out when he was talking about the Emerald study, it was a more it was a more heavily pretreated population that we saw in EMBER-3. Also, the rate of having had prior CDK4/6 inhibitors in EMBER-3 was about 2/3 or so. And Joyce had mentioned at ESMO Breast, we saw the data just in terms of the subgroups. And so I think that while you may see differences in terms of the median PFS between how well they do on the experimental arm as well as the control arm, it's really reflected by the fact that they're not exactly the same populations.
Yeah. There's a lot of questions here, as you can hear. That's why we're having the controversies with our experts. So we're going to turn to Joyce, who's going to talk about the HER2-targeted therapy for HER2-low and HER2-ultra-low disease, an area with no controversy.
Yeah. All right, so let's get going on this. And we had seen that in HER2-low breast cancer, TDXD, regardless on the right there in the DAISY trial of 1+ or 2+, IHC had excellent activity there, and it really, you couldn't differentiate based on 1+ or 2+. And of course, that led to DB04 in the HER2-low. The vast majority of patients were HR positive, and we can see on the right the very large improvement in PFS and OS. And then in the 58 patients who had triple-negative breast cancer that was HER2-low, we also see the same directional magnitude of benefit, which is actually quite impressive. But for example, on the overall survival and the updated analysis, if you look at the 95% confidence intervals, they're very much overlapping. So these are kind of unstable point estimates. So we definitely need more data, although no question, these are very interesting looking data. So in DB04, did it make a difference if they were 1+ or 2+? And you can see on the right, it didn't, because the lighter blue is 2+ and the darker blue is 1+. There was no difference there. And both down the bottom, the PFS was 10 months for both the 1+ and the 2+. So again, we really can't differentiate the coming benefit of TDXD based on 1+ or 2+. I think we know the toxicities very well. Nausea, that low-grade prolonged nausea has been solved, of course, by the olanzapine, 2.5 milligrams at HS. And for the ILD, we're hopeful we'll be able to prevent the deaths by doing CT scans every 9 to 12 weeks or so. We hope that we'll just find it asymptomatic and be able to treat it and then reintroduce it, in my opinion, at a lower dose. Now, HER2 ultra-low, we see there is now being distinguished over on the far right in the HER2 true 0, no observable membrane staining. And ultra-low is faint, incomplete membrane staining in 10% or fewer tumor cells. And of course, that was picked up and evaluated in DB06. So this is now bringing the TDXD into the first line setting, strictly an HR positive population, both either HER2 low or HER2 ultra low, centrally confirmed. And that's ultra low now is IHC 0 with a little bit of faint membrane staining. This is a first line chemotherapy naive population, as you know. TDXD versus a taxane or capecitabine. And again, we saw a 5-month improvement here, highly significant in the top left in favor of the TDXD. Survival still early. There was some crossover already, 20% in patients who got the chemotherapy, who later got TDXD. There'll be other topo-1 ADC. So I think we have to just wait till we see the final survival. And then down the bottom is the HER2 ultra-low. And across every parameter, PFS, ORR, CBR, the data in the ultra-low population looked every bit as good as the HER2 low population. Very, very interesting, sort of indistinguishable, quite active. And this was a subset analysis presented at San Antonio last year, where up at the top left, you see patients have real aggressive biology. They got less than 6 months on their first-line CDK, and you see the real split in the curves there in favor of the TDXD. Top right, 6 to 12 months, and then bottom left, more than 12 months. So the more endocrine therapy sensitive the cancer was, they still benefited differentially from the T-DXd, but it was really the patients with aggressive biology that really benefited most in the first-line setting in the DB06 here, just completely not responding to the T-DXd first line. So down the bottom right, you see January 27th, the FDA approved T-DXd for HR-positive, HER2-low, or ultra-low metastatic disease that progressed on endocrine therapy for metastatic disease, and HER2 ultra-low is defined as IHC 0 with membrane staining, 0 with membrane staining by the 4B5 antibody. So that is the FDA definition. Now, recently, the College of American Pathologists has put out a new guidance document, and you can see it's up in the red there that there's 0, which is no staining observed, 0 membrane staining, versus 0, what's being called 0+. That's membrane staining that's incomplete, faint, barely perceptible, and within 10% or fewer of the tumor cells. So that's being depicted 0+ with membrane staining. So that guidance document is out, and so our pathologists can now, it's a template for how to report the 0 and the 0+. So that is good that it is now available to us. Now, HER2 low expression is dynamic. These are two different studies. We'll just focus on the left. Over on the left, you see primary breast cancer, and on the in the middle there, you see recurrence, so that's the metastatic disease. And a lot of the zeros will go either in the second line or subsequently through the natural history of the disease over to HER2 low, because HER2 gets upregulated in the context of the cells trying to stay alive, really trying to drive resistance. And then we see that in the middle there, some HER2 lows can go to HER2 0 as well. And so the question is it really disappearing, the HER2, or perhaps it's heterogeneity within the metastasis? So if you look, for example, on the ER positive and the bar graphs in the ER positive, this is an autopsy series where all of the metastases were looked at for their level of HER2 expression, positive, 2+, 1+, ultra low, absent. And you can see there's really great variability. So we may find a 0 because we are biopsying a 0 lesion, but the fact that we had already found a 1+ or 2+ means other metastases may also be 1 or 2+. And so we know from DB04 that we definitely can treat that patient, and she will have as good a result as if she never was anything but 0 or 1. So any 0 or 1, we're good to go with the T-DXd. So we have some unanswered questions here that are being addressed in Destiny Breast 15, and these are some good size phase 2 cohorts. So cohort 1 is HER2 low, ER negative, HER2 low. We need a little bit more data coming out of the DB06 in that population. And then cohort 2 is HR negative, IHC 0. So how does this really work in the true zeros? That's a real unknown at this point. Cohort 3 is the really fast progressors, the primary endocrine therapy resistant patients. How do they do with T-DXd, HR positive, HER2 low? And then cohort 4 is HR positive, HER2 0. Again, a 0, but now with the HR positive. So these will be good data to have, very practical. Another thing, of course, that is very important with this very effective agent is to start doing combinations. So there's capecitabine, durvalumab, paclitaxel, capivasertib, and then endocrine therapy along with the T-DXd. We don't have very much data yet that has come out from those various combination studies. We do know that it's very safe to give the T-DXd with endocrine therapy, as we would expect. And this is the TALENT trial where T-DXd was given preoperatively to HR positive, HER2 low patients. And you can see over on the left, T-DXd alone had a response rate of 68%. And then adding the anastrozole certainly was safe, but it really didn't do anything. This is response rate now in the preoperative setting. So we have to wait to see some more metastatic data, but it certainly is safe to do. And then what about in combination with checkpoint inhibitor therapy? So this is first-line triple-negative breast cancer, part of the Begonia trial. This is T-DXd plus the anti-PD-L1 antibody durvalumab for HER2 low triple-negative breast cancer. And what they saw, and you can see it in the red box down the bottom right, is that it didn't make any difference. The effectiveness of the T-DXd plus durvalumab was the same, whether it was 1 or 2+, small numbers, so approximately the same. And then also up in the waterfall plot, we see that there weren't that many PD-L1 positives, suggesting that if it's HER2 low, maybe it's a little less likely to be PD-L1 positive. And we can see it didn't make any difference in terms of the benefit from this combination. So it is a safe combination. Just to finish up, there's a few other ADCs that target HER2 that are being developed in the HER2 low space. Trastuzumab deruxtecan, that is a minor groove binder, an alkylator. You can see it's active. Disitamab vedotin, that's a tubule disruptor. That's MMAE, also very effective in HER2 low. And just for the sake of time, I will just mention the bigger study that's going on. There's a phase 3 study going on. TPC and HER2 low, physician's choice here of chemotherapy versus the disitamab, which is a HER2 directed with an MMAE payload. So I just want to mention, very interesting, this Dynasty Breast 02 that's going on, randomizing patients to an ADC very similar to TDXD. It's DB1303, HER2 directed, topoisomerase 1 payload, and it's being compared in the first line setting to chemotherapies. In the first line, HR positive, and it's interesting, there's like very, very little alopecia. So very, very interesting compound, which may be differentiated on that basis. So in summary, HER2 low, ultra low expression is dynamic. It changes with therapy, is heterogeneously expressed in metastasis. New CAP guidance is available now for HER2 low versus ultra low, so we can bring that to our tumor boards and see if we can get that going on our path reports. TDXD is more effective than single agent chemotherapy, first and second line, and I will stop there.
Thanks very much. I want to get through all the pieces. So let's just talk a little bit about quickly about our cases here. So here's a patient who has de novo ER positive disease, ribo and anastrozole, 6-month progression, no biomarkers. What would be your next treatment if she had HER2 low or HER2 ultra low disease? So IHC with some membrane staining up to 10%. So it's interesting because I think there is quite a bit of variation across the group here. It's not clear exactly what we do in somebody who has disease progression at 6 months with de novo disease, so that's the only treatment that they've had, or ultra low. And interestingly, the use of TDXD seems to change a little bit from the low to ultra low. Javier, do you just want to comment briefly about your recommendations here?
Well, I think that this patient was clearly primary resistant to endocrine therapy. It's very unlikely, in my opinion, to have a good response or good activity in the second line setting. So I would like to jump into the chemotherapeutic world. So for me, clearly in the HER2 low space is TDXD. In the HER2 ultra low, I want to be very honest, I didn't read the title properly. I will go also for TDXD. Sorry for that. In the null, I will go for CAPE, but in the ultra low, I will go for TDXD as well.
But Kevin, you would give everolimus and fulvestrant at least a try?
You know, I think first of all, I will say I think everolimus is a good drug. I like to use that drug in combination post-CDK4/6 inhibition. I think it depends upon, we know that the patient was only on for 6 months. That's concerning. I think it depends on what's going on in terms of the amount of disease that is there.
Absolutely.
If the patient is symptomatic, liver mets, et cetera, I would go to TDXD. But otherwise, I would try to remain on hormonal therapy as long as I could.
So let's talk about a patient as de novo ERPR negative HER2 low disease. But IHC 1+, PD-L1 positive, BRCA negative, so wild type, receives pembro and chemo and responds, but then unfortunately has disease progression 6 months later, which is really a bummer in that setting. So then what are you going to do? Now, the group here would all give SG. Dr. Hurwitz would give TDXD. I think there's, some equipoise in that setting, but generally we're giving SG. Let's see. Hal, do you want to briefly comment on your choice?
We're going to hear about the ASCENT data soon. My growing sense, just in my own practice, has been that SG seems like a little bit more active drug in triple-negative breast cancer. And so for a lot of patients with triple-negative disease, even the HER2 lows, I will often give that drug first. I don't think we really know the answer. There's obviously no head-to-head data. But I tend to, that seems to be the pattern I'm ending up in with TDXD for HER2 positive and then ER positive HER2 low and SG more for the triple negatives.
I think that in general, that's what we've heard because of the level 1 data that we have. So now you have various patients with metastatic disease that you might be asked to, what treatment are you going to give this patient? So would you give TDXT if patient was ER negative, HER2 ultra low? And again, some people are thinking maybe for the right patient. So this is also a sequencing question because we tend to try everything that works eventually. HR positive, but true IHC 0, would you? And then HER2 IHC 0 with a HER2 mutation. We talked about that before, and I think that most of us would give TDXT or we would for the right patient if they had a HER2 mutation because there is such activity in other cancers. But that middle column, there's a little bit more question about whether or not you would give TDXT in somebody who truly has IHC 0 disease. Joyce, you would?
I think I said here, for the right patient, I'll tell you, there's a very interesting paper published a few months ago in Nature Communications showing that when you've got HER2 low, now this is a 0 question, but HER2 low, that actually the TDXT is not being internalized and releasing payload intracellularly. It's releasing payload in the interstitium by cathepsin L, which comes out of the lysosome, suggesting that 3+ it gets internalized, but 1 and 2+, it's not internalized. So that may explain why it doesn't take hardly any HER2 there to get the benefit. So it may be at the end of the day how much cathepsin L is there, how much HER2 is there. So that's why I'd consider it.
But not first.
No.
Got it. So now we have an area with some controversy. Do you use chest imaging to monitor a patient receiving TDXT who otherwise doesn't require chest imaging? Yeah, our metastatic patients, we image their chest, but on a regular basis, the recommendations of the guidelines are every 9 to 12 weeks that we get chest imaging to look for ILD. Hal, I think there's relative equipoise, but you didn't want to get chest imaging except for disease staging.
Well, I mean, we typically, in metastatic patients getting TDXD, we usually get scans every 3 to 4 months, which was about every 12-ish weeks. So that's not so off from, 9 to 12 weeks, which is the recommendation. So, if they have symptoms, obviously, if there's another reason, we do it. But when we get restaging scans, we pan scan them. I don't know, do you have like liver mets and you only look at the abdomen, I guess? Maybe that's how they do it. But, we're frequently looking at the chest. I don't mean to suggest we're not monitoring their chest health and their respiratory health. But no, I don't get a scan every 6 weeks in these patients.
Well, so there are some risk factors that have been identified to increase the risk of ILD, renal insufficiency, prior ILD, and some other factors. Rebecca, are you doing scans that, you had said yes, you would do scans on a regular basis?
Yeah, I mean, I think, this ADC, I think, is quite a different ADC than any other one, and I want to be able to give it as long as possible. And I think your data has taught me that if it's grade 1, I can give steroids and I can continue or re-challenge. And especially patients with CNS metastases, this compound makes a massive difference, especially in the triple negative HER2 low. So, I think it really depends on the patient and how often we scan. I agree with Hal that, initially, it is a lot of scans and it does expose these patients. Some of them, especially in the ER positive space, are going to live a long time and that exposes them potentially. So I work with the radiology department to get sort of a limited cut high-res CT, and I think we've learned the radiation exposure, the contrast we need, we can really kind of optimize that. So we've worked closely with the radiology department to try and to do that. But, chest x-rays don't help, PFTs don't help, O2 sats, they've looked at all of that, and it doesn't help.
And pulmonary function tests don't help. We actually looked at it in I-SPY. It doesn't seem to help. And I think, you might get it occasionally if somebody has symptoms, but generally people agree that PFTs are not helpful, except for at Memorial. But I think, we don't have Kamal here to talk about it a little bit more. And I think generally people are treating grade 1 ILD similarly with some use of steroids and some not. We showed data here that if you did receive steroids, you recover faster and can get back on drug. And I think you just have to individualize that for the individual patient. So we're going to go on and talk about endocrine refractory HR positive metastatic disease, and we'll have some more time for answering your questions as we go forward. And my topic was current and future strategies, excluding TDXT, for endocrine-refractory HR-positive metastatic disease. And I thought this was a beautiful picture. And actually, Colombo has done, although I seem to have spelled it differently in both places there, has done a beautiful job in summarizing this data. I'd encourage you to, if you are able to, hear his talk at AACR, but also to read his paper in Cancer Discovery 2024. Really lots of ADCs. And in fact, in his, he published that paper, Cancer Discovery, by AACR. He had to update everything because there were more ADCs and more information. And you can see that there's a lot of information there in terms of approvals, payloads, et cetera. And I won't go through that in detail, but it's an exciting area. And I think the one thing that we did see there is that camptothecans, which is where the topoisomerase inhibitors are the most commonly used payload, and we're all looking for new payloads. There are 3 ADCs that are approved for HR-positive, HER2-negative disease as of May of this year, and I've showed you here the different payloads. They're all topoisomerase inhibitors. As you know, there's some differences in linker cleavage. They all have bystander effect, and there are some differences in the drug-to-antibody ratio that we're learning about, as well as the half-life of these drugs and the schedule of administration, with SG being the one day 8 every 3 weeks, and the other 2 being every 3 weeks. So let's talk more about SG and Dato, the TROP2 ADCs. And one of the things that I think helps us a little bit is understanding the linkers, and we don't understand them all that well. There's a lot of differences in the linker stability. So we have the number of ADCs to date, above and below, with the different linker drug instabilities. And sacituzumab govitecan and sac-TMT, torumotecan, that we'll hear about more in the next talk, actually has they have more of an unstable linker, with the idea that you might be releasing more free drug on the cell surface, although we have a difficulty studying that. Whereas TDXT and Dato-DXT have a little more stability of the linker, and it has to do with whether the free drug or the drug linker is released in the circulation, because I think we're always having some degree of free drug in the circulation. So let's talk a little bit about the different drugs that we have approved and where we're going in the future. So TROPiCS-02 is a study that looked at sacituzumab govitecan in patients who had metastatic HR-positive disease. This was a heavily pretreated group of patients with the 3 lines of median chemotherapy, 95% visceral metastases, and 85% liver mets. So it shows you the natural history of our patients now who've received a median of 3 lines of chemotherapy for HR-positive disease. In this trial, all patients had to have received a CDK4/6 inhibitor, which I think also contributes to what we're seeing in terms of the aggressiveness of disease. 543 patients were randomized to SG or a TPC with an improvement in progression-free and overall survival, but a big drop-off right away where, we clearly are not able to understand which the right drugs are for some of our patients who have sort of overall chemotherapy-resistant disease this far out in their treatment. But the hazard ratio actually over-met its goal at 0.66, and in terms of overall survival, the hazard ratio was 0.79, as you can see here. And I think the landmark analyses can really help in these late-line settings where you saw 3 times as many patients free from progression at 12 months, and the improvement in survival at 12 months, I think, very clinically relevant for our patients. There were also more responses, and I think the interesting aspect of SG is the toxicity with neutropenia and diarrhea. The diarrhea we kind of understand at SN38, active metabolite of irinotecan. Across the studies, we've seen about a 10% grade 3 diarrhea rate. The neutropenia, again, we've learned to manage with growth factors, and I'll show you some information about that in a moment. Alopecia is pretty much universal with SG, despite what we saw in the clinical trials, I think, in our clinical experience. Again, question of whether or not this is free drug or the particular topo-1 inhibitor. We know that irinotecan is metabolized through UGT1A1, and in fact, when we looked at the poor metabolizing phenotype with pharmacogenomic testing, we found that patients who had the poor metabolizing phenotype have more grade 3 diarrhea and neutropenia, which helps us with dose reducing in patients who have diarrhea, I think, and feel comfortable they're seeing quite a bit of drug. And then a group has reported data, Perez Garcia, looking at prophylactic growth factor and loperamide, and showing if you give a fairly hefty dose of loperamide and growth factor, that you can really markedly reduce the all grade as well as the higher grade neutropenia and diarrhea and eliminate permanent discontinuations in this 50-patient study, as well as decreased treatment interruptions and dose reductions. So there are definitely ways to manage it. We don't recommend giving all that loperamide up front. Patients who are at risk for neutropenia definitely use the growth factor, but the loperamide really you have to individualize for the patient and their own experience. Datopotamab deruxtecan is a second TROP2 ADC that was tested. Now, sacituzumab was already approved for triple-negative disease and based on TROPiCS was approved for pretreated hormone receptor-positive endocrine-refractory disease. Datopotamab was tested in a less heavily pretreated population. Here, the median number of lines of chemotherapy was 1. Patients did not have to receive a CDK4/6 inhibitor, but 82% had. And they were randomized to receive Dato versus TPC. Again, Dato is every 3 weeks. What was shown was a significant improvement in progression-free survival with almost an identical hazard ratio to TROPiCS-02 in the more heavily pretreated population of patients, and then a longer time to subsequent therapy, as you would expect with a more effective agent. The effectiveness of datopotamab was seen regardless of the duration of prior CDK4/6 inhibitor therapy, and I don't think we expected that that would really impact the second-line chemotherapy in this setting. So, of course, one of the second primary endpoints was looking at overall survival, and we saw no difference in overall survival here. You can see the hazard ratio is almost dead on 1, with a median overall survival of about 18 and a half months. So the question was whether or not that was due to sequential therapy. So was there crossover? Everybody's receiving very effective ADCs, so therefore you can't really see the effect of giving this effective drug in the second-line setting. And what does sequencing mean? So they adjusted the overall survival based on use of subsequent ADC, and in fact, twice as many patients who were on the treatment of physician choice received TDXD or SG, but most of them were TDXD, versus 12% in the datopotamab arm. Now you can see that now there is a numeric difference in median overall survival, but even with this adjustment, it didn't achieve statistical significance. Very hard to adjust for subsequent treatment when it varies to such a degree. In terms of toxicity, Dato has some unique toxicities, stomatitis, as you can see here, and then keratitis, dry eye, which we haven't really seen in the other drugs, but we're seeing in some other TROP2 ADCs. And you can see some of the information here, which will be published very soon with the survival data. ILD is very uncommon with Dato-DXd. One patient was felt to have died by the adjudication committee from drug-induced ILD, but the investigator felt it was related to disease. So we're really seeing much less ILD with this lower DAR and different target. So the datopotamab deruxtecan is the most recently approved ADC, approved at the end of January this year for patients who've received prior endocrine therapy. And the FDA, which was so interesting in a line of chemo, recommended steroid mouthwash and cold chips. Now, we feel the steroid mouthwash works, but there isn't prospective data as yet. We're hoping to acquire some over the next year. So there is a first-line chemotherapy trial with SG versus treatment of physician choice after endocrine therapy, and that trial has completed accrual, 2-to-1 randomization. We're waiting for results. And then Trophuse 010 is a trial with a new TROP2 ADC, sacituzumab deruxtecan or SAC-TMT, 1,200 patients, and in this population, first line, the drug is being given with or without pembrolizumab, although these patients have PD-L1 negative disease and compared to treatment of physician choice. Lots of questions coming up, and one of the questions is, what about these new drugs? Patritumab deruxtecan is a HER3 ADC with the same payload, deruxtecan, a drug-antibody ratio of 8. We have seen significant efficacy in patients with HR-positive, HER2-negative disease who've received prior chemotherapy in the metastatic setting, and some efficacy as well in the neoadjuvant setting. And the toxicity appears to be quite modest for patritumab deruxtecan, with some thrombocytopenia, nausea, some fatigue, and actually a little bit of diarrhea, more diarrhea with this drug than with TDXT or Dato-DXT, 10% of grade 3 or greater. And this drug is now being studied in additional trials outside of breast cancer, but more trials in breast cancer are ongoing and planned. It's a little bit hard because we got the same payload. And then here's an anti-HER2 ADC that was studied in China, SHRA1811, where they also saw significant efficacy in HR-positive HER2 low disease. I won't go through this in detail, but they have very low rate of ILD. That was was presented at San Antonio. There's also a B7H4-directed ADC with a dolasynthen auristatin payload, and that actually showed some efficacy, not great, in hormone receptor-positive disease, but they had a median of 7 lines of prior treatment. So the plan now is to move this a little bit earlier in the course. And then there's another B7H4 targeted ADC called PSAM, Emily and PSAM, and that drug, B7H4, is expressed in HR-positive disease, and they saw nice responses in a mixed population, also presented at ESMO Breast. And there are many others in phase 1 trials. And then lastly, just to mention this really cool new concept, which is using a peptide drug conjugate as opposed to an antibody drug conjugate. The peptide is part of an antibody. It still gets incorporated into the cell when it binds to the receptor. This is a Nectin-4 payload with an MMAE, a Nectin-4 target with an MMAE payload that is being studied in triple-negative disease and will be studied in HR-positive disease as well. There are a number of trials looking at sequencing ADCs, which I think is going to be really important in our patients with HR-positive as well as triple-negative disease, and we'll see those results in the future. So let's go on and talk about what we're going to do with patients with ER-positive disease with ADCs. So a 65-year-old woman has de novo ER-positive, HER2-negative, again, IHC0, not 0 plus. She gets ribo and anastrozole and progresses at 6 months. So she doesn't have any mutations. She gets capecitabine, but still has disease progression. So what would you give the patient now? She's had capecitabine. She only got ribo and anastrozole and not fulvestrant. So some people would consider giving fulvestrant or imlunestrant with abemaciclib. But others would use an antibody drug conjugate in this patient who's having disease progression after capecitabine. Let's see. Joyce, how would you decide what you were going to treat with in this case?
I've had experience when patients don't benefit from either palbo or ribo. I've had experience switching over to abemaciclib, and I've had some durable responses. And so the imlunestrant and imlunestrant abema combination looked more effective than the fulvestrant abemaciclib, assuming availability. So I would actually give her another try at a CDK4/6. But then
now it's not worked. So you've given it. She's progressed in 3 months.
She's progressing through that one.
What are you going to give now?
2. So now I do, and she's already had CAPE as well. So in this particular case, I would be thinking about sacituzumab versus datopotamab. That's what I would be thinking about. And I think I would talk to the patient about it, but the every 3 weekly datopotamab has a lot of appeal to patients, of course. We practice in the inner city, hard to get to, parking is expensive, et cetera. So I think I would probably talk to her about datopotamab.
So, Javier, you would give sacituzumab?
Certainly. I think that we have data with survival as well. Median PFS is hazard ratio for PFS is basically identical between dato and saci, so both are good drugs. When you do the sensitivity analysis for survival, removing those patients who receive subsequent lines of ADCs, survival is not achieved yet. So I would prefer sacituzumab with the data we have in survival, but I would feel very comfortable also with datopotamab.
So now we have, how are you really comparing efficacy and tolerability for dato and SG and HR-positive metastatic disease? So most people feel, we're not sure the efficacy is about the same, and tolerability. What do you feel? I mean, everybody here has given the drug quite frequently. Rebecca?
So, yeah, I mean, we've done it mostly on trials, and I have to say, I think because we had the experience previously with dato, we knew about the mucositis, the stomatitis, and so we've been giving ice chips and popsicles and giving the mouthwash. And so I have to say, my patients are finding it extremely well tolerated. I agree with you, the every 3-week dosing. I have patients that come around the region in Southeast Asia. They like flying in every 3 weeks. It's a lot more agreeable for them. And that's important to patients. They just say walking in the building stresses them out. And so coming every 3 weeks, that's schedule. I don't like the day 8 of SASI, to be honest. I find that day 8 stressful because I always get a call. So I'd have to say that's what I'm finding so far, but you do have to do the prophylaxis because once you get the stomatitis, it takes longer to recover than an everolimus type stomatitis. So that's the big difference. You have to get on.
Looks more chemo-like then.
Yeah.
Hal, you thought SG was more tolerable.
Well, apparently it's very expensive to park in Dallas, but you can fly into Singapore pretty readily every 3 weeks. Our patients usually use private jets, and so it's not a big deal to come in once every couple of weeks.
Landing on the roof.
I don't honestly know which is better. I've only had a little bit of experience to date with the datopotamab. The mucositis and the eye thing is a bit of an annoyance for the patient, so I probably still give SG at this point, but look, here's the other dilemma. We're giving all these drugs to these patients, right? I mean, we're pretending like we're only going to give one ADC in the course of the disease. Every patient of mine who has metastatic disease is now ending up getting 2, if not more, ADCs. And so, again, the issues which we should be thinking about as a very pragmatic set of clinical trials are to compare them head-to-head, to see if there really is a difference if you switch the antibody target versus the payload, to see if second-line ADC really does any better than good old Taxol. I mean, I've had some patients who've gotten all these ADCs, and then you finally give them some old, real chemotherapy, and they have excellent responses for a very long time. So, it's a wild, wild west situation out there. There was some interesting data at a poster today from Caris where they're trying to look at this with outcomes, and I got to say that in the real world, none of it looks so fabulous. These patients are all progressing in 2 to 4 months. But these are important practical questions. If you're at a site which has seen a high volume of these patients, you can begin to ask these questions in collaboration, and it would be great if people did that. And I also think that we've reached the point where we should not be supporting clinical trials because there's a new ADC against standard of care chemotherapy. I mean, we've done that. We now have 3 approved agents that we know are better than standard of care chemotherapy. So the FDA needs to, they got a lot of things to figure out at the FDA these days. But one of the things they need to figure out is to say, look, if you're going to get approval for the next ADC, it should be against an existing ADC. It's pointless to just
that's a really good
otherwise
point,
keep
Hal,
doing
actually, that, we really need to be thinking about changing. And it goes along with what was talked about earlier, that, we don't want to give single-agent endocrine therapy most of the time either, just sometimes. So we've talked about this as the toxicities that are the major issues with datopotamab that means that we have to hold the drug. But the proportion of patients who get the mouth sores, of course, I think, overall with those of us who've given it maybe more or less, we have not that much difference. And I think, the chance of developing mucositis and whether or not you're using steroid mouth rinse preventively really does play, I think, a big role here. And then the chance of developing ILD. So it's kind of intriguing that we saw so much less ILD, even though there is deruxtecan, not only with datopotamab, but also with patritumab. I'm curious what people think. I don't know, Kevin, you want to comment on why you think the ILD is so different between these agents?
I'm not sure, right? Like it's a interesting finding. I'm not sure if it has to do with the linker or what, but I because clearly it's the same
Linkers
payload.
are the same, yeah.
Yeah, it's surprising to me, but I don't know that I have a great answer to that.
So I have a question from the audience before we go on to our last talk, which is really an interesting one. So if somebody's getting genomic testing for ESR1 mutations, doing ctDNA, camizestrant isn't approved. Somebody has the ESR1 mutation pops up. Are you going to use elacestrant instead? Kevin, you gave that talk.
I right now would not. I think that it was one of the comments that Angie had mentioned during her talk of like, could you just substitute in a different SERD? I mean, do I think there's the same sort of proof of principle? Do I think that there's really a difference between elacestrant and camizestrant or any of the SERDs that we really have in terms of their efficacy in ESR1 mutations? I really don't at this point, but I will continue to wait for PFS2 and longer-term follow-up.
Anybody else would? Javier, yes, no? Just a yes, no answer.
No, I didn't answer about this question because I do not have any experience with datopotamab. It's not approved, so look at the literature. So, but I think that we have to acknowledge the clinical trials.
You have a one-line answer here.
We have to acknowledge the clinical trials. I think that if you design a clinical trial and you have good results, we shouldn't extrapolate to other drugs because at the end, so no, I would keep on Cami.
You would?
I would continue with Cami.
Oh, you're not got Chemi yet. You continue with the AI and the
Okay, yeah.
4/6
Right.
inhibitor.
Right.
And that would mean you generally wouldn't test because you have nothing to do. Yes, no, answer, Joyce?
I would, in certain
Yes, no.
circumstances, for example, the marker's rising.
Yes, no.
She's got,
Would
yes.
you
I said yes.
substitute
I would use the,
elacestrant?
yes.
Okay. Rebecca?
I don't have access right now.
Okay. This is regulatory issues aside.
I know, but I decided to pull that card at the very end.
Okay.
So no.
All right. Okay. So yes, no. So you can see there's no equipoise here. So we're going to go on and talk about an area potentially with a little less controversy with selection of therapy for metastatic TNBC.
So I'd like to highlight, thank you so much, Hope, that we had 4 sessions on metastatic ER-positive breast cancer. That's clearly where all the controversy is. Javier and I got the easy jobs, HER2-positive, triple-negative. I really don't have that much controversial stuff, but hopefully I can tell you about stuff to come and let you know where things are at. So I think, there are great guidelines out there. If you look at ESMO, you look at NCCN, the immediate divide up front is it's PD-L1 positive, is it PD-L1 negative? And that's where the guidelines are very similar. If they have a germline BRCA mutation, I'll be honest, many of us, that's maybe an area of controversy, but most of us prefer an IO approach first line because that's the strength of the data in that first line setting. And so we have many positive trials that show us that in this first line setting, the Impassion 130 was with atezolizumab for SP142 positive patients. As we know, that label doesn't exist in the US, but in the rest of the world, that's actually still approved in many countries around the world and is an option for patients. If you look at Impassion 131, though, solvent-based paclitaxel was used, and there was not a benefit. And so I tell people, if you're going to give atezo, make sure you give nab-paclitaxel. Keynote 355, as we know, was one of the other larger studies that had different backbones. PD-L1 score of CPS greater than or equal to 10. There was a positive PFS and OS benefit. And now we have Torchlight, toripalimab, and nab-paclitaxel versus nab-paclitaxel. That's also a positive study for PFS and OS. So I think the data there is very strong. Now, as Hope showed us a few years ago already, looking at the different sort of chemo backbones was so important to give us options for our patients in clinic. NAB-PAC, solvent-based, or gem-carbo, which as we know in that first-line setting, patients really don't want something that we have hair loss. And if you can dose modify the gem-carbo, it's actually quite well tolerated. We also know that this includes patients with CPS scores greater than 10, and lower that a little bit. I think the only thing of area of controversy is that, remember, none of these patients got adjuvant immunotherapy, and let's be honest, most of us are now incorporating it in a lot of our patients with adjuvant therapy, or neoadjuvant therapy, and then adjuvant, and that's where the controversy is. Here, if you look at the Keynote 355, it's a very small number of patients, but there didn't seem to be as much benefit in those patients that are relapsing 6 to 12 months after their adjuvant therapy. So we did a study looking at giving atezolizumab plus carbogem or capecitabine versus the standard chemotherapy in those early relapsing TNBCs, and we didn't see any difference in OS in the PD-L1 positive patients. So, either there wasn't a benefit, maybe it was the wrong immune checkpoint inhibitor, maybe we didn't select the patients right, but certainly it didn't seem like there was a benefit. This is such an area of unmet need, PFS of 4 months, OS of 12 months, and if you actually look at the PD-L1 negative patients, that OS is like 9 months. So these are patients that still are an unmet need, and I'll talk about how we're gonna fill that unmet need. So let's move on. So if the patients, if they're PD-L1 negative or they've had, immune checkpoint in the first line setting, then we're talking about BRCA PARP inhibitors. Now, this has been around for a while. Remember, there are 2 registration trials looking at PARP inhibitors versus standard of care chemo. Big caveat is those patients, the control arm did not include a platinum because that wasn't standard of care at the time. This is the data. It's really quite amazing how consistent the data are between these two. There's an absolute benefit of about 3 months. Remember, this is compared to chemotherapy. This is taking a tablet. My patients love taking these medicines. It's really easy to take. You dose adjust. They adjust the dose at home. The response rate is well over 50 to 60%. There was doubling compared to chemotherapy. Again, it's amazing that just a tablet can make such a big difference. And that's why both of these trials clearly showed a quality of life benefit to switching to PARP inhibition versus chemotherapy. The big thing that's changed is Hal's colleagues, Nadine Tung and colleagues had looked at, can we go beyond germline BRCA1 and 2? And this data suggests you can. Specifically the germline PALB2. I find these patients, and what we're seeing is that responses are much more durable in this PALP B2, and this is what I'm seeing clinically. So I think it's very reasonable in these germline PALP B2s. We're also seeing some subsets of somatic BRCA1 and 2, so we're doing mutational testing now a lot, and I think this approach is very reasonable, and this data supports that. There's also some new generation. I don't have time to get into all the DDRs, but I wanted to mention saruparib. You can see there lots of activity. I'd say the only thing is we were really hoping that this was going to be less myelosuppressive so that we can combine it with other agents. I don't think it is. So I think stay tuned for some of the next generation PARP inhibitors. So then finally getting to sort of back to the ADC space and understanding how these fit in and can we move these in earlier line. I think you've heard we have 3 TROP2 directed antibody drug conjugates. And what's fascinating is that they have different drug antibody ratios, they have different toxicities, they have different schedules. All 3 have different schedules. So you've seen the ASCENT data. This is what cemented sacituzumab. You heard from many on the podium that their go-to drug for triple-negative breast cancer is sacituzumab, and that's because of this trial, the largest randomized trial. Patients had received a few lines of chemotherapy already, and yet we look at those dramatic curves in terms of overall survival. So this really has become our go-to drug, but it's not in first line. It's after they've had 2 or more chemotherapies. Then we see data for sac-TMT. So this is a compound that was developed in China. The phase 3 data last year, they didn't reach, in terms of the median overall survival, they did not reach median overall survival with this compound. So very similar to the ASCENT, that had 2 or more lines of chemotherapy, but the PFS data, the OS data is very promising. What's interesting about this compound is that the toxicity profile is kind of in between sacituzumab and datopotamab. So it has a little myelosuppression, it has a little stomatitis, but it doesn't have diarrhea and it doesn't have ILD. So, I'm not clever enough to tell you why that's so. It doesn't sound like they were either, but I do agree with that. That paper that came out was really interesting looking at the differences in terms of systemic release of payload. And then, as you heard at this meeting, the OptiChop Breast05 study. This was a very small study, again done in China, but it was first line. It included PD-L1 negative and PD-L1 low, so CPS score less than 10. And again, I really just wanted to highlight because those waterfall plots are quite impressive. This is the first line setting. And so why this is so important is we have the Trophus 11 study. So this compound's been taken over by Merck. So you're going to see a ton of studies with this compound, sac-TMT. And so I think we're really excited to see how it performs in a Caucasian-based population and a larger group of patients and understanding a bit more of the side effects. We saw some data with the Tropion-01 study with datopotamab. We're now awaiting the Tropion-02 data, which is in the first-line setting, looking at data very similar to Tropion-01 in the ER-positive space. We're going to be looking at this in the triple-negative first-line space. By the end of the year, you will see this data. And finally, I think you heard already, Destiny Breast 04, there was this small subset of triple negatives. They were very brave to put those in, but really an impressive survival advantage. I agree with how SASI is my go-to drug because it was a larger randomized trial, but I have patients who have brain mets. This is a good option for patients. And so I think it's very reasonable to consider in those patients. Finally, ADCs, there are many on the horizon. Erica Hamilton has shown us, and we heard a little bit about the B7H4. Even at this meeting, I think in triple negative, there's some really interesting and cool compounds, as you'd said. Nectin-4, in those hard-to-treat cancers like bladder cancer, these are interesting ADCs. Hopefully, we'll see different payloads as well. And then finally, combining ADCs with immune checkpoint inhibitors because ADCs upregulate STING. We're hoping for some amazing synergy in changing the microenvironment. And the key thing is here, we might not see big differences in PFS, but we might see differences in overall survival and getting that tail of the curve. When you affect the microenvironment, that's really how you transform cancers. And we saw that with some of those earlier studies. At this meeting, Sarah Tillany showed us the pivotal data, first-line trial, PD-L1 positive, looking at the combination of chemo plus Pembro versus SASI plus Pembro in that first-line setting. And what you can see here is an improvement in PFS, which is solid, but I think this is sort of 4 months improvement in PFS. What we really want to see is the PFS too and the overall survival data. And there was a lot of crossover to their credit in this trial. And so we're waiting for that long-term outcome. But remember, 50% of patients in triple negative never get to second-line therapy. So I'd say this is a bit different than the other spaces that you heard about. If people aren't alive enough to get to second line, that's a problem. So I'd say the final thing is I was worried about toxicity about combining SASI and Pembro. I was truthfully quite reassured that we didn't see any new safety signals. We're good at managing IO now. We're good at managing sacituzumab. So finally, these are the trials to watch out for. So ASCENT-03 and Tropion-Breast-02. So basically looking at SASI and Dato, both TROP2 directed ADCs. These will read out by the end of the year. And then we have a number of other ongoing trials. So with that, hopefully I was just a little bit, but almost there.
You're great.
Thank you for your attention. The other compound to look out for is the bispecifics, looking at VEGF and PD-L1. Again, if you target the microenvironment in TNBC, that's where you see impact.
Okay, that was great. And, there's so much going on in this space now. Again, less controversy, but a lot going on, which we're excited about. A press release with ASCENT-03 also. So now you have a 65-year-old woman who has de novo triple negative disease and a germline BRCA mutation. In patients who are PD-L1 positive, we at Equipoise, everybody would give the checkpoint inhibitor. I think the question about which chemotherapy partner, of course, this was before ASCO, and there may be some differences in what people choose. I think for triple negative disease, maybe more of us would choose SG as the first line and use our taxane next. But I think that again, as you heard from Rebecca, there's some controversy for PD-L1 negative disease. Again, I think that if you live in Europe, you can give bevacizumab, but those of us who can't. And I think it depends on whether you're going to give SG in the first line setting or if somebody's PD-L1 has a germline BRCA mutation, olaparib. And we might be able to go back and deal with one of those questions. I think the patient has triple negative disease who's progressed after first-line Pembro and chemo. We generally will give olaparib, and it just really depends on the first-line therapy to some degree. We want to get that checkpoint inhibitor in, usually before you've had resistance to platinum, since that seems to be cross-resistant. And then other DNA damage repair pathways where you get a PARP inhibitor. And I think Joyce has the one difference area there. She'd try some other areas as well, but mostly we think about PALB2 being the same as BRCA2. So I went through those very quickly just because I wanted to be able to go back to this first slide and just talk a little bit about the ASCENT-04 data and whether it would change your standard of care now based on that data. So Javier?
No, I completely agree with Rebecca. I think that for me, I voted this before ASCO this year. So for me now, without any doubt, sacituzumab govitecan plus pembrolizumab, based on the 50% of patients that will not reach second line, in my opinion, has become the new standard of care.
And then when you have a patient who has a germline BRCA mutation, you would potentially, Kevin, give something before olaparib?
Yeah, I mean, if somebody has a PD-L1 positive tumor, I'd like to give the checkpoint inhibitor just for the hope that maybe they would be at the tail of the curve and be a durable responder. So that's what I generally do.
Yeah, I think that, a lot of it depends on, of course, on how much disease the patient has as well. And then I think the other question was, would you actually use a PARP inhibitor in patients who had other types of mutations? Joyce?
Yeah, I mean, the PALB2 data.
Okay, but how about the other ones?
Oh, yeah. Well, those are known to be HRD mutations. So I have patients with those, and those are HRD mutations. Some of them are not ATM, CHEK2, no, but these are.
Yeah, Nadine's data didn't show any responses in that subset, but maybe there might be some, which you've seen.
I have seen, I've seen real cures with DNA damaging agents in these patients.
Okay. Really interesting. So one of the questions that came, we're going to circle back to HER2 positive disease here for a minute. Do you get baseline brain MRIs in patients when you're trying to decide about what treatment you're going to give patients? Cleopatra DB09. Hal, do you get baseline brain met?
Typically not in an asymptomatic patient. There is a finite rate that if patients at presentation will have it, but it's less than 10%. So usually if they're clinically without symptoms, we don't scan the brain.
Does everybody pretty much agree with that? No, you get a baseline brain MRI, right?
I actually don't get it immediately. Like somebody walks through the door, de novo metastatic, big cancer, stage 3. ER negative, I treat her. Pre-op, go to surgery. I get a brain a few months down the road. I've been burned in that setting with significant seizures in the ICU because I didn't look. So I just give it a little time to see if it's going to be there, and I look.
I think there's a low threshold overall, and if you are having difficulty with decisions, that might help as well. So I want to thank our panel tremendously for their excellent work and great conversations. It was a great discussion, and you're going to hear even more controversy at San Antonio because we will have had 6 months to percolate all this through. We'll see what's approved by then. Thanks very much.